So good morning and welcome to, I think this could be our 22nd webinar that we've done. And Laura Gage, who's our marketing manager, who does a lot of these, is on holiday at the moment. So unfortunately, you've got me, a poor substitute, but here we go. Recovery4Life are a member, and they're a valued member of the NEA. They do a lot of work with people, and more recently with COVID and the problems that we've got. And the purpose of this webinar is just to look at some of the situations that are arising regarding people. I think we've got an ongoing issue at the moment. It's not a stop-start thing. I think no matter what people tell you, I think it's a bit of a journey that's unknown. And John's going to give you some of the information which hopefully will help you develop a strategy with regards to people, because the best companies, in my experience, are companies that actively pursue strategies, not just talk about them. So without further ado, I'll hand you over to John, but I'll just say one thing. I've sent everybody an email. Just please email me on that email address. I've sent a chat to everybody just to confirm that you attended, because I haven't got the list. And if you want to use the chat, please do. It's at the if you highlight the bottom of your screen, you'll see a chat box. If you want to put any questions to John at the end, that's fine. And I'm sure John's going to present and allow us enough time to have a discussion as well. So without further ado, I'll hand you over to John. Thanks very much.
All right. Well, first of all, thank you, Stuart. Thank you, NEAA, for having us back. We clearly didn't put off too many people for the last two we've done. But this morning, we wanted to focus on risk management, and particularly the risk management of people. So if you could share the slides, Stuart, that'd be great.
Yeah, got them.
That's great. Okay, so I'm going to just a little bit about background on us. If we can move on to the first slide, Stuart.
Yeah.
So if you move on to the next one now.
Yeah, I'm just, yeah, got it, yeah.
Yeah, lovely. So what I'm going to talk about, first of all, I want to make it clear, we're expressing our opinions based on a range of research we've been doing, a lot of technical and specialist advice we've been taking from people like, we work closely with an infectious diseases consultant. We've got our roots are in primary care. And for those of you who don't know us, we're a specialist drug alcohol and mental health service. And working with businesses, we work cross-sector, primarily across the Northeast, but also around the country. And one of the things that has might not seem a natural fit from the outset, but hopefully you'll see where this fits together later, is that with the COVID crisis, as it's the pandemics which emerged at the beginning of the year, we've been working very closely with our existing clients to develop risk management strategies and models around the people side of risk, and how the pandemic, an unprecedented situation, has impacted on the people side of businesses. Now, what I'm not going to talk about is individual. I've been on a few risk management webinars, and much of the focus is on almost like the reporting or management tools that people use to develop risk management frameworks, or indeed people will distribute a certain framework. Well, actually, if you look at the different sectors we work in, the different companies that who will be attending today, for example, I'm not sure that's actually very helpful, because we'll all be using different systems and different processes. But I think the fundamental issue here, and this is why it's a starting point, fundamentally what we're all doing, whatever system you use, is we're looking at the balance between probability and impact. And this becomes at the sharp end for businesses coming forward because of the particular and peculiar aspects of COVID-19 and how it works and how it's impacting on people. Next slide, Stu. So today I really wanted to focus on three main things. First of all, an understanding and our understanding of where we are now, what the people risks are that actually come out from this, and where we need to factor these in. And the starting point for that will be where we were before the pandemic and what it's likely to look like going forward. And then actually the third section, and possibly the most important, is actually about what people need to be doing for planning for the return within their risk management structures. Next slide. So just as a background, there's fundamentally, if you look at there's lots of controversy around different approaches to how governments have approached the pandemics. We've primarily been looking at, really, we started looking at this initially through a very strange route last September, October, because we have links with China. But actually, really, it's seriously, we started looking at this from around January, beginning into February. And fundamentally, just to put the context, put a little bit of structure around this, national governments have taken two main approaches. The first is the test, track, isolate approach, which has been very successful in places like New Zealand, South Korea, Taiwan, Vietnam, and in much of South Asia. Japan's just opened its doors recently to easing lockdown. To a herd immunity approach, which has been very much taken up by, is the UK strategy, it's what's happening in the US, etc., etc. Now, the reason this is important to flag, these aren't political points, actually the two strategies taken by governments have actually impacted and will directly impact on what happens in the workplace. If we go back to Sir Patrick Vallance's statement on the 13th of March, the Chief Scientific Officer, the stated aim was to reduce the peak, broaden the peak, but not suppress it completely. And this was with you basically working on the theory that actually by building herd immunity, i.e. you infected lots of people in different ways or let it to sort of run its course pretty much, it will sort of produce a resistance, a natural resistance in the community. However, if we move on to the next slide, it actually throws out a lot of issues, particularly around the science, and science is being bandied around quite often. Unfortunately, the UK government hasn't published any of the scientific advice that's been taken, that it's been taken and based its policies on. But what we have got is a wide global scientific consensus on a number of points, of which I'm going to go through some. The main sources of guidance we'll say, and for references on this, is we don't do our own research deliberately, but what we do is we pick out reliable sources of information, say WHO or the Office for National Statistics, etc., and we comment on them. So what we think we know, and I would emphasize what we think we know because the situation changes all the time, is that if you look at the consensus of the main studies, including from people like Columbia University in the US, that did a survey of 375 Chinese cities. There's a lot of data out there which can give an indication of what we are currently dealing with and what we can expect. So one of the using different modeling tools, and we take the sort of middle path from all of these research papers that have come out, is that actually what we think we know is that 20% of the UK population has already been exposed to the virus. Of this, 80% of those people will either have very low symptoms or will be completely asymptomatic. And the asymptomatic issue is possibly the biggest issue we see that will affect the workplace going forward and needs to be built into risk assessments as quickly as possible. Of the people who are symptomatic, the experience is that the three main criteria, which are going to be the foundations for the tracking policies and procedures that are going forward, 88% of people experiencing symptoms will show a temperature, they'll have a cough, and they will lose taste and smell. The highest group of that is the temperature, that's the 88% figure. About 60% of people will have a cough, and actually I think it's roughly the same, a little bit less for the loss of taste and smell. However, what this means in broad categories is 12% of people who do show some symptoms will not necessarily be picked up by any of those tracking mechanisms, or indeed are within the figures that are being quoted, that are being targeted, particularly for testing going forward. Next slide. So what do we know? What are the facts? And facts are, we're not talking old facts or, you know, new facts or fake news or anything. The facts are that we're actually, the UK has the highest second death rate in the world. ONS projections are looking at a death rate of over 60,000 people. We've had over 300 NHS and care workers have died already. I think the last figure was about 312, but it's gone up since then. And that's a really important figure because this is unprecedented for the number of people who've been exposed, and would indicate that actually the amount of viral load is a key factor in the transmission and the impact that the virus has. What is interesting is that testing capacity has increased, but the actual number of tests actually carried out has dropped off. And the primary reason for this, we know this because a number of labs, we pretty much every week we get about 3 or 4 different labs, many of them NHS labs, contacting us saying, do we need any extra testing capacity because the testing capacity isn't being used. Now the real reason for this is because testing is only being targeted at people who exhibit the main symptoms or self-report or live with somebody exhibiting symptoms going forward. Now, this really shows the focus is about, in many ways, it's looking at testing people who are already ill. Now, that actually is exactly the right focus for the NHS. It's about identifying people who need the most resources. It's about making sure that resources are available for those who need them. But it actually doesn't help in terms of transmission and incubation rates, because people are most at risk of transmitting to other people and most infectious up to 72 hours before symptoms actually appear. So in many ways, symptoms is telling us, testing in that context is telling us what we already know, i.e. somebody is showing illness. Next slide. But there's lots of things we don't know. So the very first thing is we don't know how long antibodies stay in the system and how easily triggered these could be by re-exposure to the virus. We don't know the levels of long-term immunity, though research from South Korea is actually positive on this. And the impact of asymptomatic carriers and super spreaders have been estimated around 60 to 86% in other environments, and there's lots of issues around both cultural and sort of population densities and things like this. But there's clearly a very high level of asymptomatic carriers out there. It's not known how many variants of COVID-19. Over 30 have been identified already, and we don't know if they'll mutate any further. And the impact on specific demographics, such as BMI, age, ethnicity, etc., is only just starting to be understood. But the big one, and to be honest, is that we don't know how many cycles or waves of the virus we're likely to experience. Unfortunately, it's almost guaranteed we will experience a second wave, and the early lockdown, the easing of lockdown restrictions actually might bring this, the second wave, earlier than we expect, which is forecast for sort of from the autumn into the winter going forward. Next slide. So what did people do when during lockdown and, 2-3 months possibly on furlough, in isolated conditions away from the workplace, or going to work in a state of fear? Coping mechanisms and destructive behaviours are very common, and if you look at the increase in particularly the use of alcohol, Alcohol Change UK put a study out a few weeks ago, which estimated that around 33% of people basically admitted that they were drinking a lot more than they were previously. But actually, if you look at how other mechanisms that people sort of deal with, sort of self-comforting measures would include drugs, illicit, prescription and over-the-counter. Gambling has gone through the roof, particularly online casinos. We're not eating properly. We're eating there's a lot of baking going on, especially in my house, I have to admit. But either under-eating, overeating, a healthy diet has suffered, as has physical activity. There's been a huge increase in violence, particularly domestic violence, over 300% increase over the past 3 months. Self-harm's increased, and suicide and suicidal ideation with a recent local charity in Durham, for example, who identified 270 increase in all tidal falls. So if that's what the situation getting worse, if we just, I'm going to whip through these very quickly because I think and we'll circulate these after the event. But actually, the situation we were dealing with in the Northeast particularly wasn't particularly great, and nationally, beforehand, particularly in relation to the sort of drug and alcohol, substance misuse and mental health issues. So very quickly, what you've got there is the estimate of 30 billion impact a year on to impact upon mental health, which is pretty much the tip of the iceberg. Drug misuse is usually underestimated at 800 million per year. Estimated 17 million working days lost each year in the UK due to alcohol misuse, and the annual cost to industry caused by alcohol is estimated at 7.3 billion. Well, those figures are certainly going to go up. We'll move to the next slide. If we look at the national stats around, most of these come through the ONS, where you have 27% of employers admit that drug abuse is a problem at work already. This is pre-COVID. Again, the loss through working days through alcohol. Around 75% of regular drug users are actually in employment because drugs are expensive and you need to be able to pay for them some way. More than 1 in 6 people aged 16 to 24 takes drugs regularly. That's something in particular with apprenticeship programs and young people entering the workforce. And drugs account for as much as 80% of losses due to theft in the workplace. Now, I have no idea how they calculated that, but that's a figure quoted by the insurance industry on which decisions are based on how they set insurance premiums. So that's something that affects everyone. And from really focuses our thinking in terms of risk management going forward is that alcohol is implicated in 40% of all workplace accidents, and 60% of workplace fatalities have alcohol as a factor. So these are the risk elements that we need to focus on as we go through. We touched on drugs. Prescription and illicit over-the-counter drugs are on the rise. We've got a whole range of NHS figures sort of prescribing, which can cause induced dependency. And these are particularly drugs like antidepressants and painkillers. These are only going to go up in usage across the Northeast. Move on. Next slide. And I'm going to whip through these really quickly. So the environment we're working in is that we've got the highest number of drug deaths at 77.4 per million pre-COVID. Next slide. We've got highest use of codeine and painkillers, prescription and over-the-counter painkillers that include codeine in them, anywhere in the UK. Next slide. Money Supermarket identified Sunderland as the drink and drug driving capital of the UK. Next slide. Northeast, we've got the highest use of prescription and over-the-counter medication in the UK. And then we move on to the next one. Just to put this in context, these are the figures from 2010 for the prescribing of opiates in the UK. Now we quote the UK figure, the 2010 figures, because the most recent figures have been presented in a different way, but are actually much worse. They're about a third higher. What we do to look at, without even looking at the figures underneath, is compare the amount of opiates as the categories, comparing London, the lowest use anywhere in the UK, compared to the Northeast. Next slide. Alcohol, we're a big drinking area. We've got the highest level of alcohol-related hospital admissions, highest level of binge drinking, and the highest level of death rates, 22% higher than the national average, according to ONS in 2015. Next slide. We've also got the highest levels of mental health and I'm not going to go through all of these, but particularly the prevalence of diagnosed depression in Hartlepool and Stockton, South Castle Gateshead, are considerably higher than the national average, on average around 3% higher. What's also interesting, the Royal College of Psychiatry published a report recently where their members noticed that 43% of psychiatrists have seen an increase in urgent and emergency cases following COVID lockdown, with 45% saying that they've seen the routine appointments drop off. And this is a major factor both for mental health but also for physical health going forward, because that is also reflected in primary care and secondary care appointments for standard sort of health monitoring and underlying conditions. Next slide. Sadly, what we also see is the North East has the highest suicide rate in the country. And predictions, if they're live from University of Sydney, for example, are forecasting an increase in suicide rate by possibly up to 25–30%. Next slide. Now, one of the things we only know about, if that's what was pre-COVID, what are we looking at now? Now, this conversation isn't to scare people or anything like that with the presentation. Our belief is if you know what you're dealing with, you can deal with anything. But the one thing we do know is that the world we know tomorrow and what's going to emerge over the next 2 years is going to be very different to what it currently is or currently was. Next slide. So what we don't know is the population's susceptibility for COVID. It just isn't known. So everyone's assuming it's everybody, 100%. Risk of infection is known to increase with age, and comorbidities, things like diabetes, hypertension, obesity, respiratory diseases, etc., are key factors in the spread and the impact that the virus has on the individual. There's also this issue around viral loads, because what is clear in the death of the NHS and care workers is that the more a person is exposed, the greater the risk of and severity of infection as it goes forward. Next slide. So what we also know is that the poorest areas of the UK have fared worse in terms of infection. Sunderland has the highest number of cases per 100,000 in the UK, for example, and the North East is an area of high deprivation, always has been, and health inequalities. These factors, such as Middlesbrough and Hartlepool, for example, being the top 10 most deprived areas, will have a major impact, have had an impact, and will continue to do so. Next slide. So really, when we bring this down to what can we do about it, it really comes down to, we would suggest, sort of 4 main categories. First of all, the virus itself, physical health, short, medium and long term, mental health and social impacts. Next slide. So the virus in many ways is the easy bit. Everybody's working very hard and looking at the physical and environmental controls. It might not feel easy if you're actually currently doing it, but compared to some of the other issues, actually there is government guidance. People understand social distancing and are sort of sorting the workplace out with screens, etc., etc. People understand hygiene and the importance of it, and there is a growing understanding of the role of PPE for different environments. Next slide. However, the physical health impacts are yet to be known. First of all, the actual impact post-recovery from COVID really isn't known, and there is some evidence that actually increases if you've had the virus. There is an increased risk of stroke, COPD, etc. We also don't know the impact on existing underlying health and conditions, etc. The mental health impacts, again, are as bad as the physical health impacts, if not potentially worse going forward. And particularly, we don't know what the long-term impact will be. Some studies coming from SARS post-16 in China show that up to 40% of people returning to work had PTSD, for example. So issues around anxiety, around health, family, employment, etc., trauma, PTSD, suicide, and the risk of suicide is going to be a major theme that needs to be addressed in everybody's risk assessments. And particularly the impact on the focus of, if you look at where people look at behavioural health and safety, for example, we need to think that actually people won't all be coming at it sort of fresh, etc. People will have other things on their mind. And this comes back to that list earlier. I talked about the coping mechanisms. These we need to bear in mind. So if you go on to the next slide, it's time to prepare. So the 4 main areas that are risk assessment we need to really look at. Physical safety, we've touched on in line with the other slides. Psychological security is going to be a key issue. You can make people feel comfortable, not just coming back to work, but being comfortable that they're not going to pick something up in the workplace and bring it home. And the impact of loss, of grief, of people who've lost people or know people, or the fear of it, or people who have been ill, we don't really know what those long-term impacts are, but also what services and programs they offer need to be able to address that. And this really is an opportunity to renew and re-establish the psychological contract between employer and employee. Next slide. So the priorities I would suggest for any risk assessment would be you need to identify and understand your workforce. The first thing you need to do is to find out who has actually had direct experience of the virus and how it's impacted them. You need to look at the existing mental health conditions of your staff, and you need to look at people who've got carer responsibilities, both for children and for particularly for older parents, and the impact that the pandemic has had on them. Furloughed staff and the separation between the company, particularly if you haven't had very strong communications between your furloughed staff and the company, needs to be handled very carefully. And I would just flag again the impact of PTSD, which normally will not come through for 3 to 6 months after the episode is finished. So if you look at it, people are returning to work in June, you would expect to see PTSD starting to emerge really from sort of September or afterwards. Next slide. So as a minimum, we would suggest you need to look at physical environmental redesign of the workplace. Many people have done that. Access control policies, particularly if I'm going to come back to if you're just relying on temperature checks. You need to look at refreshing your health and safety training. And really, we're suggesting that when you're getting people back into the workplace, treat everybody as if they've been on long-term sick. You wouldn't expect somebody to come back from 3 to 6 months of long-term sick and go straight back into the workplace. You would get them to refresh their health and safety training, and you would get them to be sort of coached and go through all those policies and safety issues again. We would always recommend reissue your drug and alcohol policies, offer help to people if they need it, but just remind people that this actually is a key issue in your approach for safety in the workplace. If you haven't got mental health services, support services, etc., it's time to get them, and you cannot rely. Public services are absolutely overwhelmed at the moment, so not just with waiting lists and things like that. It really is a time to look at what support your company can offer. And it's a perfect time to use all of these issues to communicate and rebuild your teams now. Next slide. So wherever possible, use your existing resources. Check that your EAP lines, if you have them, and your mental health programs, understand and can work with trauma. If they can't, find another ones. If you get stuck, come back to us, we offer them. But we always say use your existing resources, but check that they're up to the job. There's a huge power in volunteering and CSR programs, and this is a good point to try and, if you can harness those sort of programs to rebuild your teams, it's an efficient way of doing so, and it works. And do think about amnesty periods if people are struggling, particularly with alcohol, but also with drugs. Next slide. And test. If you notice, I mentioned testing up to now. But the real point with testing is if you look at going forward, and I'm going to give you an example, testing really is the key to this, and has been proven in every environment and every country where they've managed to actually get to grips with the pandemic in a quicker way. So if we move on to the next slide. I will use us as an example. All 3 of us have had COVID, and that is my little test. And I'm sharing it for a number of reasons. The first of all is that none of us had a temperature. None of us had coughs. None of us had lost the sense of taste or smell. And by any standards, without testing, we would have been able to go onto any client site and basically spread the virus around. So there are three different, for us, we showed the antigen test negative. We showed a positive IgM test, which shows that potentially you can transmit the disease. But we also showed the IgG test positive, which the antibody test, which there's a lot of conversation around. Next slide. And what this really means is what we need to avoid is the situation of Mary Mallon at the beginning of the century, famous Typhoid Mary, who was an asymptomatic carrier, knew actually she had it, and still carried on working and infected. She ended up being sentenced to a self-isolation program for over 20 years by herself because she wouldn't stop working. And this is a real issue, particularly if you're dealing with contractors who may know they're ill, who can't afford not to work. They may not know that they're asymptomatic, but some will. And that is another risk that you need to build in, into your risk assessment, particularly if you're not testing. You need to think of a way up how you're going to manage that risk. If we move on. So in summary, what we do know is that it's a changing environment, and the understanding of COVID is changing almost on a daily basis. We've got a 12 to 18 months minimum of the current situation. We definitely have to develop new ways of working and living, and we need to constantly review the risk assessments as the evidence changes and from what you find in the workplace. So if we move on to the next slide, the final slide, this is actually the main sort of services Recovery4Life offers, but I put it in here not as a sales job, but actually it really are the categories that any risk assessment that you need to look at for your business. Really, they're your headings, which we would suggest you might want to look at to support your business going forward. And on that note, I would be happy to take some questions. I would also say that we see this as the beginning of a conversation, and we'll be very happy to follow up with any questions we don't get covered now.
Thanks very much, John. If anybody wants to ask a question, just unmute yourselves in the bottom left-hand corner of your box, and just ask a question. Has anybody got any questions for John?
Hey, Stu, Ron Cole here. There was a question that came through the chat box from Martin Taylor, and it's interesting stats on the impact of alcohol on workplace accidents and fatalities. Do you have a source for further research, John?
Yeah, there's a number of sources. So, yeah, to be honest, health and safety stats from the UK are pretty good in terms of how they've been reduced. So most of this information comes from the HSE. But actually, there's some very interesting global studies as well, which give parallels. So what we can do afterwards, you can just Google them straight off. But I think the TUC also have produced some good figures. But they're just some headline ones, primarily coming through the HSE. There's some good studies also, I think, came out of Italy and the US. I think it was actually somebody like the Teamsters Union and the Postal Service did particularly good pieces of research around both drug and alcohol impacts on the workplace. But we can follow those up with you if you're interested.
John, what about getting it again? What's your thoughts on that?
Well, this is the really interesting one because people just don't know. So if the predictions are that you've got 100% susceptibility, it comes back to this issue about getting it again. This is why testing is so important, particularly for identifying the antibodies. So the real issue, if you notice, there's been a big hoo-ha in the press about, or a big fanfare made about the antibody tests that have been back to lab tests. Now, the real problem with them, and they've been around for ages, we've been using them for quite a while, it's just that it's the first time they've been formally bought by the NHS. And there's about 9 different companies who are supplying them. But the real issue with that is it's not known, first of all, if the antibodies, how long they stay in the system, and also if they can get reactivated and whether they're effective in being reactivated going forward. Now, some of the reason this is important is with the 2 points is, first of all, the problem with the IgG tests, as they currently are, the back-to-lab tests, is they don't identify the IgM antibody, which is the bit which tells you whether you're still can transmit the disease. It tells you that your body is, the IgG shows you've got the antibodies. The second piece is known is everybody's immune system's different. So it's not sure how long they will stay in the system. And we're doing a couple of tracer studies at the moment to see with some of the clients we're working with, see how long they're there for. And then the third point is there is evidence from SARS and various other sort of similar viruses, which would indicate actually it doesn't give permanent immunity. And particularly from the SARS study that was done in, I think it was in, it was China. What it indicated is it might even potentially weaken the immune system going forward for a secondary infection. Now, hopefully not. That's off a different virus, but that's the sort of problem. And if you look at Ebola as another example of a virus, it's not clear, really isn't clear. People have had it for a second time. So this is why, if you're taking a risk approach to this, it's not about just waiting and expecting that you're going to have permanent immunity. You've got to monitor it constantly, and you've got to review your risk assessments to be able to see how it's going to impact your business. Does that make sense?
Makes sense, John. Makes sense. Has anybody else got any questions for John?
Was there a little question there in the background? I can't remember. Couldn't hear.
No, it's probably my wife working from home, John.
Oh, right, okay. But I think the key point here is, I would add, is that if people, none of this is to do, it's scary enough as it is, but if you can identify it and build it in from risk, in your risk systems from the outset, and this is what risk professionals are really good at. This is what health and safety teams are really good at. It's about identifying risk. And then if you're not sure how to deal with it, get in touch. Because actually, this is really applying what the sort of clinical risk management is about, and how that then impacts on sort of workplace risk management. And that's really what we're talking about here. It's about bringing those two disciplines together to get the result really to keep businesses running.
Yeah. Right, if there's no more questions, I'd like to thank John for his time this morning. I think it's always good to get a different viewpoint from a professional who's working in a different environment all the time, which just happens to be really important at the moment, John. And I've recorded the session, and I will send out the presentation to everyone. And either contact John or myself if you want to pursue this further. I've put my email address on the chat. So without further ado, I'd just like to close the meeting, and thank you all for your attendance.
No, and thank you, Stuart.
It's a pleasure. It's a pleasure, John. Thanks again. And thanks all for attending. Cheers.
Bye-bye now.
Bye.
Do you want to stay on for a minute, Stu?
I'm stopping on, John. There's a couple of people still on. If they want to talk, they're more than welcome.
Yeah.
No. Darren's there still.
Actually,
Maureen's still here.
a bit of clarification.
I'll unmute Maureen as well, so that's she's on the...
Yeah. Testing. How do you go about testing your staff?
Well, to be honest, there's different ways of doing it. We sell tests, okay? So, and this is why this is in the sales pitch today. This is why I've not gone into too much on testing, because it's wider issues. But what I'll do is afterwards I'll send you some information. It depends.
Yeah, that'd be great.
The key thing here is where, and it sounds counterintuitive, but we take the same approach we do with drug and alcohol testing, which is actually we find sometimes either people aren't doing it testing for the right things, Well, often it's the wrong drugs they're looking for, but also sometimes they over-test. And the real approach we take is you've got to understand what it is you're trying to achieve, and then you target your testing for that scenario. But sorry, go on.
Yeah, this is what you were saying about your HR policies and procedures, because
Yeah.
obviously, I mean, I know of an employer that basically sacks an employee because he wouldn't adhere to the safe social distancing, and he was a repeat offender. So it's like you said, it's I guess it's having to build it into your HR policies and procedures.
Yeah.
As well.
Yeah, it is, and I think we actually have been working with some clients and actually producing a specific COVID-19 policy that covers things like social distance adherence policy. But what's really interesting, and I think it's too early to tell, take that example you gave of somebody who wasn't adhering to social distancing. Actually, there's a fundamental issue and we don't know the situation. Was it willful? Was it because he actually just wasn't there? What we're seeing is a lot of people essentially, to use the old term, shell shock, coming out of isolation.
Yeah.
It'll be very interesting. 2-3 indicators we'll be watching will be the number of crashes, road incidents that will come through on people coming to and from work, because people just aren't thinking, they're already doing it. The second thing will be the number of workplace accidents that would take place, which wouldn't normally happen. So the real driver on that was the experience in India when they reopened up the gas pipeline and 12 people were killed because they stopped following what the health and safety procedures that they'd had in place. Normally that wouldn't have happened, but the number of accidents there have gone through the roof.
Yeah, I think Deuce and Babcock some years ago developed the behavioural management for health and safety.
Yeah,
and I think that kind of like covers your behaviours. What stops you from actually doing something, or
absolutely.
what ensures that you do so.
Yeah. Well, we've actually developed, and again, it's not a sales pitch, because we're developing with some existing clients, basically an online screening tool. It's a self-reporting one, but it's benefit for the individual. You're using the same principles as occupational health, basically, where it's completely anonymized information going to the employer, but it gives a snapshot and an understanding, a tracking almost of what that workforce is going to be, how it's feeling, how it's acting in things, both mental health wise, but also around testing. And I mean, we developed this because it really hit us a while ago that if you look at the stats and where people are looking at access controls onto sites, only 48% of people will even figure 52% of people who could have the virus will not be picked up by those systems.
Yeah.
Now that's the scary bit.
Well, that's it. I mean, you have to be careful, don't you, with regards to what you hear on social media and what you hear in the news. But there's the theory that people may have been exposed to this as far back as December of last year, and I don't know.
Well, to be honest, what is clear, people will have been exposed to this as far back as December.
Right,
yeah, absolutely. And I think the real problem here is, and working with, like, taking advice from community, from the research papers, because we've got 3 points of research. One is our medical director is a very senior GP who is actually the chair of the commissioning for all of Sunderland's health and mental health services. So we've got the view from community. We've got the view from a professor at Durham University who's a biology sort of research and teacher, who is keeping us abreast of the research side of it in particular. And then we've got an infectious diseases consultant who's saying, actually, guys, it was him who flagged it straight away. You need to bear it. The real danger for business isn't the symptomatic people, it's the asymptomatic people. And there was a terrible case in Florida, just as an example. There was a funeral, and they would allow 10 people to the funeral, of which 6 died within that family who attended that funeral from an asymptomatic carrier. That's how serious it is.
Yeah.
So if you don't, the only real sure way of doing it is a multi-systemic approach, which is how we've approached it, where you do temperatures, you do self-reporting, but you also need to have testing there, because not everybody's going to be honest. If you're going to lose your livelihood, and you've got what you're seeing as if you don't get paid sick pay, or you're only going to be on SSP, people will take a risk. It's human nature.
Yeah, I think they mentioned about the antibody test, that people would potentially go out and try and contract the virus.
Yeah.
So that they then can be tested for the antibody test and then go to work. So
yeah, and it really doesn't actually help. I mean, to be honest, if I'm being really honest, without being political on this, we don't really we stopped following PHE advice. In terms of we recognise it, don't get me wrong, that's the legal framework. Yeah. But actually, the most effective stuff is what's been done abroad. And if you look at South Korea, I was on a webinar with South Korea last week, and this was amazing. They never actually, their economy has only really been affected by exports, not through the internal economy, because they never actually had to lock down firmly, because from the day one, they launched into this prepared testing, tracing, and isolation program. And to put this in context, there's a big discussion around the schools. We're going to put out a few opinion pieces on LinkedIn, which it will make a connection to be interested. But there's a really telling one. Britain started easing after 56 days. China, which was worst hit, but they controlled it once it sort of stepped out. They released after 72 days, okay? And that's with those controls in place. We're releasing with 56 without those controls and without tracing in place before easing a lockdown. If you look at the school situation, South Korea is 2 months ahead of us down the line in what's actually happened. And they've been able to keep working, no furloughing, no huge impact as it has here on the economy, right? But what's really interesting, even though they're 2 months ahead, and have, as they believe, really confined the virus, they still won't open the schools because they see the risk is too high. And that's with all those measures in place.
Yeah, I've got children who don't fall into the category that are due back beginning of June. One of the misleading things is the concern that the children get the virus and therefore make themselves ill, or is the concern that the children get the virus and spread it to vulnerable people? It's both. Yeah.
Yeah, it's not true to suggest that children can't catch it and they're not impacted.
Oh no, I know that they catch it, and to be quite honest, you wouldn't take the risk with your own child anyway, would you? Regardless of how low the risk was. Yeah. What they're saying is the risk is lower.
It is, and it's a really interesting one, because if you look at the risk, the Daily Mail put out a thing about asking teachers to be heroes like the NHS heroes.
Yeah.
Now, our roots are primary care. We know a lot of people. We've released a lot of sort of nurses and people who do sessional work with us just to concentrate on that sort of stuff. And what's really interesting, these people don't want to be heroes, and they wouldn't have to be heroes if they've been given proper PPE.
Yeah.
All right. And now this is the real point. It is unprecedented that many people have died who actually look after people.
Yeah.
Ebola didn't kill that many. All right. So when you're looking at it like that, at what point, and it's an opinion piece we're going to put out, but it's based on the international research and the international guidance and what other people have done. The real question here is, with all risk, and we're very much taking this from a risk basis, if you look at it this way, what is the tolerance of risk that companies and individuals are willing to take? So the really important question is, what is the tolerance of risk given that the government will not publish its scientific advice on what's its decision to open the schools? One of the chief scientific advisors on SAGE said actually the decision was made at cabinet, and they have not done a risk assessment. Okay, full stop. And Michael Gove was on telly saying he could guarantee that the schools were safe, and then in the next sentence said, but there's always risk. Okay, so my question here is, and this would be to any government, any party, what is the acceptable level of child and teacher deaths that would be acceptable to open those schools?
Well, it'd be zero, wouldn't it?
John, why didn't you get into the BBC? Question from John from Gateshead. It's a good question.
Yeah, well, but see, we're trying not to be political. It's an interesting one and we're going to put a piece out about it, because actually this is the fundamental issue, is we're talking about the economy. When you look at, and again, it's not being political, but there's been, and actually the furloughing and the support to businesses, it could have been better in certain areas, but it's unprecedented, right? And it was good that they've done it. However, let's put this in context. We've probably spent somewhere between, the estimate will be about 86 billion by the end of the lockdown, they think, by September or something. We've bailed the banks out to 500 billion. Yeah, when we go back, and we could afford it then. This is about the whole economy, and more importantly, if you were to be really sort of step back and look at it as we've been doing it from a cold perspective, possibly, is okay, what is the price of a life, and how important is that life? So when you've got, again, 13th of March, Boris Johnson talked about taking it on the chin, or is it the 3rd of March, taking it on the chin, and that we would be doing well. He accepted that lots of people's loved ones would die, and that we would basically be doing well if it was 20,000. That was the model they were running to. 20,000 deaths was acceptable, okay? What is interesting is we are far beyond that, okay? We're up to at least 60,000. And the proof on a local level is Martin in his practice, our medical director. In a small GP practice, an average number of deaths in a week, and these aren't hospital-related deaths, and they're not people in care homes, but these are community deaths. An average death for a GP would see maybe 3 a week for a population of about 15,000 in a practice like that. They've seen it up to 29 a week in one GP practice. Those figures are not counted in what we're talking about.
Yeah, true. Yeah.
Okay. And that's where it becomes problematic. So the real issue, bringing it back to risk, is that's the bit that we see. And we have so many employers saying to us, oh, well, the NHS will sort out the testing for us. Well, that's sort of like shutting the barn door after the horse has bolted, because your transmission is 3 days before symptoms turn up. Can you see what the problem is?
Yeah.
The only thing I would add, Darren, is unfortunately I've been having to work with a lot of companies and try and understand what's going out there, not from John's level of medical kind of perspective, but like the facts that are out there. And after Boris said his last announcement on I think it was the Sunday, about being use your common sense.
Yeah.
A 50-page document that came out, and it's on the government website. I don't know if you've read it, Darren.
Well, but no.
I would encourage you to read it, because it's long-winded, it's repetitive. But what I'd done, I basically thought, for my own sanity, I read it, and I took out about 20 points that I thought were relevant. And the big points are, they may never find a cure for it.
Yeah.
And then they're starting to drip that out into the media, and you'll hear on the Daily Mail or whatever that there's You know, you hear somebody puts on social media they've got a new a new bit of kit that'll stop it in its track. It's all if you go onto the government website, it tells you very clearly we may never have a cure for this.
Yeah.
But they won't tell you that at the briefing. They'll sort of allude to it, so I think you've got to go to the source of the information. That source isn't on LinkedIn. It certainly isn't on Facebook.
No.
And I think if you use your common sense, after reading that, you wouldn't go out your front door.
Yeah. And I think, you know, it's the problem I find with companies as such, and they stated it quite clearly, is that they've reacted very well to putting measures in place with regards to COVID-19. But that's the problem that most companies had before COVID-19, is that they react.
Yeah.
They don't. You know, where's the prevention?
Well, I attend a meeting every Thursday, and it's all the big tier ones and Nissan. And the feedback is from the staff that they've brought in, some of the skeleton crews.
Yeah.
Safer at work than they do in a supermarket.
And I think what we're seeing is people have got their heads round implementing social distancing, hygiene, and PPE. There is a big issue around procurement of PPE, which is going to be huge come September, October. So we've actually, because one of the things we didn't want to profit, we didn't mention it earlier, we didn't want to profit from the pandemic, basically. So the profits from the testing we've been putting into what we call the 2020 fund, which we've been buying PPE for care homes and sanitizer and stuff. We dished out 1,000 bottles of sanitizer earlier on in the month, but we've been doing that since we started testing, basically. So from March, and we've raised about 8,000 on this, which we've dished out. We put money into food banks and all that. But what's really interesting, that gave us two things. It gave us a real insight to what's really happening on the ground. And this whole thing about PPE, what the biggest problem is, the NHS's procurement approaches have been ridiculous. And the standards they've been looking for they are rightly the highest in the world. But if you ask a care home, do they want a face mask or a visor that will match, X standard, or nothing, they will pick something which just will be a barrier. So we dished out loads of visors and stuff like that. And then what was worrying was the number of GPs and people who actually came to us for testing and stuff like that, which we donated, all right, for frontline workers. Now the real point here is, when it comes to things like PPE, it's people like, and with some of our clients, the price of a face mask, for example. Normally, a clinical face mask, which are only really used in clinical settings, okay, would cost maybe 30 pence if you weren't buying in huge bulk, 25 to 35p. They've gone up to nearly £2 each, right? Now, businesses can afford that. Care homes and community groups can't. And that's why we've actually got currently 27,000 face masks in stock. Yeah. And we're giving them or with some people would donate, in some with the clients we're getting them where they need it, if that makes sense. Yeah. But again, you've got everybody's trying to fish in the same pool, and it's really damaging because there hasn't been a proper strategy on PPE. It's very interesting. One of the clients we've got, which we were amazed at, because actually we were told, who knows, we might end up as Northeast exporter of the year. Was
hey guys, I'm going to have to bow out. Okay.
Yeah,
thank you, Stuart.
Yeah, thank you.
All right, cheers, mate. I don't know if we'll get cut off, Darren. If we do, I'll drop you a line. But what was interesting was the peacekeeping force in the Sinai Desert is using